Good evening. I'm Peter Lennox. I'm a plastic surgeon in Vancouver, British Columbia, and it's my pleasure to join you for a Bra Day this year. I will be talking about medical devices in breast reconstruction with a focus on several of these. So medical devices are routinely used in breast reconstruction surgery, and innovations have led to changes in the way we do this type of surgery. And in the course of my career, things that we do differently that have been influenced by devices include nipple-sparing mastectomies, direct implant surgery, fat grafting, and DF microsurgical reconstruction. Health Canada classifies medical devices as 1 through 4, which is an increasing risk. The medical devices used in plastic surgery are 1, 2, and 3, with breast implants being in class 3, and we'll talk about those. So the devices that I've chosen to focus on in breast reconstruction include breast implants, obviously, tools to assess tissue perfusion or blood supply to tissues when we're doing surgery, and then implant support devices, which are synthetic meshes or biologic materials. And I'll start with those. So supports are a variety of devices that can be used to support a breast implant or a tissue expander or the soft tissue in a reconstruction. They are also often used in revision surgery to control the pocket or either itself or around a breast implant. They are classified as either biologic or synthetic. Synthetic supports are usually absorbable, and they're woven of a similar material to the type of sutures that we use that are dissolving. And so they tend to be a mesh-like material. Biologics are derived from either human origin or, animal or human tissue, which is usually human skin or dermis. They both have advantages and disadvantages, which your surgeon would be able to review with you if one of those were going to be used. And so this is an example that you can see of an ADM in this case, which is a biologic support being used to support the lower half of the breast implant in a direct implant reconstruction with the muscle covering the upper part. And so it basically acts like an internal bra or sling to support the implant. And this is just a case example. This is a patient who had previous breast implants in when she was diagnosed with left breast cancer and had bilateral mastectomies, which were skin-sparing mastectomies, and direct implant or one-stage reconstruction with implants and using acellular dermal matrix in the lower half of the breast. They've also been increasingly used in prepectoral reconstruction, which is putting the implant on top of the muscle, which may have some advantages. And again, they're used as a sling or an internal support of the implant, as well as improving the soft tissue coverage over the implant. The next thing I'm going to talk about is assessment of perfusion or blood supply to tissue. There are a number of goals or reasons to do this. So we can reduce the amount of tissue that might be injured or die when we do skin sparing or nipple sparing mastectomies, reduce flap loss when we're using a patient's own tissue, make better decisions intraoperatively in terms of where we do incisions, how much skin we can keep, things like that, and then reduce cost to the systems through complication reduction, but more importantly, the negative impact on patients. This is probably the most commonly used perfusion assessment tool in Canada, and it uses a dye called indocyanine green, which we can give to the patient, which causes fluorescence when you shine a laser on it, and then a camera can pick that up, and it can tell us in a sort of number term how much blood supply there is to an area of tissue. And so this is just the camera apparatus that we use to pick up on that. It generates 2 images. One is called grayscale, which shows you actual blood flow in the tissue. And then the other one is a static image, which is color coded, which gives you a number ratio of how much blood supply there is. And so this is just both of those. So this is the nipple with the incision on a nipple sparing mastectomy. And you can see these white areas are the blood vessels coming towards the nipple. The darker areas are area where the blood supply is less or is more questionable. And so on the color one, you can see this is 100% perfusion, and this gives you relative value. And this is tissue that wouldn't survive. And so we can make the decision in the operating room to remove it so that everything survives and reduces complications. It allows us to use different incisions, perform nipple sparing mastectomies, direct to implant reconstruction, and as I said, minimize patient complications. Lastly, I'd like to talk about breast implants. So when we think about breast implants, they're fairly straightforward. There's a shell, which is always a solid silicone, and that can be smooth or textured. There's what it's filled with, which is in Canada, either saline or silicone. And then there's the shape, which is either round or shaped. There are 4 manufacturers in Canada approved by Health Canada: Mentor, Allergan, Sientra, and Ideal, which only make saline implants. And as I mentioned, there's 2 main types in Canada. So saline implants, which is the silicone shell filled with sterile saline or salt water. The big advantage of them is that if it ever leaks or ruptures, you detect it right away because it goes flat. They have more ripples, they have less natural feel, and they can potentially deflate over time. Silicone implants are a silicone elastomer shell that's filled with highly cohesive silicone gel. They feel more natural. They have less rippling, but they don't deflate over time. The problems then is that they potentially can be undetected if they have a rupture. The gel doesn't go anywhere, but you have to do surveillance to look at them. As we mentioned, implants can either be smooth or textured and round or anatomic. The implants, as we mentioned, are fairly simple. So solid silicone shell and then different fills. As I mentioned, in Canada, it's only silicone or saline. I won't go into detail on this other than to say that newer silicone implants have a much more highly cohesive gel, meaning the gel inside is much more thick and sort of like a gummy bear, so it can't go anywhere. The outer shells have been improved so they don't have gel bleed. So if there is a rupture or leak, the shell will stay intact other than where the tear is, and the gel won't go anywhere else. Breast implants do have problems, so these are the well-described complications of them. So implant failure, reoperation rates, implant malposition, capsular contracture, palpability, visibility, rippling. And then the last 2 things I want to talk about are breast implant-associated anaplastic large cell lymphoma and breast implant illness. So ALCL was first described in 1995, and it's a type of lymphoma or cancer that can form around implants in women. They have only been seen in textured implants to date, and the more aggressively textured the implant, the more common it is. There have now been 1,130 cases reported globally, with 59 deaths and 8 bilateral cases. This is simply the demographics at presentation, and the most important thing on this slide is that ALCL almost always presents with a large fluid collection. So in about 80% of women, they have a sudden increase in the breast size, and there's fluid around the implant, and that's where you see those abnormal cells. This is the distribution in Canada in 2018 and 2022 when we started collecting the data. Not surprisingly, the largest numbers are in British Columbia and Ontario, which have large populations and a history of a lot of use of textured implants in the past. So in summary, for ALCL, the Canadian prevalence, risk, and demographics are very similar to comparable global variables. One thing that I find very frustrating, which I brought up with Health Canada, as I know Dr. Brown has, is that we still do not have a national implant registry or implant ALCL database that is run by the government. Good news is that all of the new cases in the last 3 years have been low stage, meaning they were found very early and they're treated with simple surgery and no other treatments needed, and expectation of complete cure. Breast implant illness is the last thing I want to talk about. This is an entity where women who have breast implants, either for cosmetic or reconstructive reasons, develop a group of symptoms which they feel are related to their implants. And they're vague constitutional symptoms, so chest pain, back pain, neck pain, muscle pain, fatigue, brain fog, things that are difficult to quantify. There's no agreed upon diagnostic criteria. There's no blood test for it. When you take implants out, about half of women report getting better in terms of their symptoms. A recent study showed that there's no change in improvement of symptoms, whether you take the implant alone out, a limited capsule removal, or what people refer to as en bloc capsulectomy. So the questions for breast implant illness is it real, and how do we identify it or diagnose it? What causes it, and can we prevent it, or are there individuals that shouldn't have breast implants in the first place? So in summary, medical devices are essential for many types of surgery, including breast reconstruction. Higher classes of devices, such as breast implants, may have associated risks, and they require ongoing surveillance and feedback to identify any new emerging concerns. And finally, devices have resulted in advances in breast reconstruction options and outcomes for patients. Thank you.